Welcome to Raising OKC Kids, Conversations with Metro Family in Oklahoma City. I'm Kirsten Holder with Metro Family, and I am joined by Steve Hodges, MD, a pediatric urologist who is here to talk about kids and bedwetting. Welcome, Dr. Hodges. Thank you so much for joining me today.
And thanks so much for having me. Really appreciate it.
Yes, before we dive right into the questions that everybody is just dying to know, I'd love to give a little background on you. Steve Hodges, MD, is a nationally recognized and board certified pediatric urologist. He is currently an associate professor of pediatric urology at Wake Forest University School of Medicine. Dr. Hodges earned a BA from Duke University and an MD from Wake Forest School of Medicine, where he also completed his residency in urology, followed by a fellowship in urology at Children's Hospital of San Diego. His work can be seen in numerous publications such as Huffington Post, Slate, the New York Times, the Washington Post, and so many more. So I'd love to just start out with a really broad question. What do you see are the most common myths about bedwetting?
Yeah, and this is honestly the hardest part about dealing with bedwetting is because the appearances can be deceiving. So what parents or other doctors even honestly see when they see bedwetting children are the obvious things. There's a child that's just laying in a pool of urine, right? So two things that they typically notice are the amount of urine. So it appears as though they're making just too much too much pee. It can't be that much. That can't be normal because they're sitting in puddles. Parents will say there's puddled urine in the sheets. And then that ties into the second thing is why aren't they waking up? How can someone sleep through this? They're a very deep sleeper. They're hard to wake up. They're hard to arouse. And so that component of just making too much urine in general and the sleeping too deeply are the two main myths that we struggle to fight against in treating bedwetting.
Hmm. Yes, and you've, I'm sure, heard those things so often, including my child has been potty trained for months, for years, but they're still having issues with bedwetting, even though the child might not have accidents during the day. And like you mentioned, we assume the most common reasons are the deep sleeping. Maybe they're not developmentally ready to stop using a pull-up. So I'd love to hear a little bit more on your thoughts on those reasonings that we tell ourselves as parents. Do you agree with that reasoning? And while each child is certainly unique, what do you see as the most common reasons for bedwetting?
Yeah, so I personally, I mean, it's controversial slightly, but I don't think that urinating while unconscious is normal. I don't think it's physiologically normal for anybody. So at any age. So you can have variations in terms of how old the child it needs to be to get to the bathroom on their own at night if they were to wake up. Because if you have a child in a crib that's scared to leave their room, then they may wet themselves just because they have no option. But if we're discussing kids that are voiding while unconscious, then I think there's two important things to keep in mind. Number one is that everyone that is mature enough to wake up to urinate wakes up to urinate. It doesn't matter how sleepy you are. You can be passed out from a long night of working, like when I was a resident, or you could have guzzled a huge Gatorade or something right before bed, or my father who's got a large prostate has to get up at night. You're aroused because those signals all go to your brain, um, and that's how adults urinate. Infants, if anyone that's had child knows, they void by spontaneous reflex. So they're just you could be changing their diaper and they'll just start peeing and be completely oblivious. They're just staring at the mobile or something.
We
And
love when
so
that happens, when feeding everywhere while we're changing diapers.
right? And they don't even know it's happening, right? So that pattern shifts at some point to the adult pattern, but it's not a on-off switch. So as you're transitioning and as you age and you potty train during the day, there is some persistence of this infant reflex. And as a parent that there's a lot of reflexes kids have that go away, like when they reach for the milk or when the way they grasp onto things. There's a lot of infant reflexes that slowly taper. And this reflex voiding is another reflex. And so all bedwetting is a persistence of that reflex that's set off. And in older kids, and that can be normal up to 2, 3, 4. But if it's persisting in children that should otherwise be able to wake up and get to bed, it's always persisting due to abnormal rectal dilation from constipation, and we'll get into that. But that's basically what it is. It's a persistence of an infantile voiding reflex due to um, fecal impaction. I hate to say constipation because that implies certain things, but basically kids that aren't emptying their poop in a timely fashion, if that makes sense.
Interesting. Yes, and I'd love to know more about that. I do want to talk about bedwetting remedies that maybe do more harm than good before we get to solutions, if you don't mind.
Sure. Yeah, totally.
So a lot of us that grew up, we were maybe taught a certain way to stop bedwetting, or maybe saw our siblings do it a certain way, our friends. So some of those that you suggest might do more harm than good are giving rewards, like a sticker system or treats or something for not bedwetting. Maybe leaving kids in the wet sheets or other, punishments that might be a little cruel, limiting liquids, holding urine to strengthen their bladder, waiting for them to just outgrow it. Some of those techniques, admittedly, sound a little archaic. Others might feel harmless to us, but I'd love to hear from you what each of these, may or may not be helpful in a situation where a child is too old to be bedwetting and yet still is.
Yeah, and I think those first few you mentioned all imply that the child has some kind of agency involved in the bedwetting. So if you make them, some parents will make them change their sheets or make them feel it. They take them out of pull-up so they feel wet, or they'll make them something. It all imply, or rewards. It all imply that if you just want it bad enough, you'll be dry. And so, as we mentioned earlier, this is a reflex. It's not something that happens. And it happens when they're unconscious, so they can't control it. So I hate to lead into that, even if it's well-intentioned with rewards, because you could say there's nothing wrong with rewards. But then the flip side of that is the punishment, which we see all too often. Incontinence in children is it's a leading cause of child abuse, and so I really try to focus in my work to stress the fact that this is not something under the child's control. So we focus on the real causes, so we can get it fixed, and everyone can be a lot happier. And then the waiting to outgrow it is honestly reasonable, except that you don't know when they will outgrow it. And after the age of 5, in which about a quarter of the kids wet the bed, about 15% get better a year. And for most people, that's fine. But I see college kids that are wetting bed, and I could not imagine 15 years of changing sheets, and something that would be otherwise treatable. And so we really try to treat them pretty aggressively. But I never push the treatment. If a family is fine to kind of always bring up that the treatment shouldn't be worse than the disease. So if wetting bed at 5 is not a big deal, and they don't want to do our treatment protocol, that's fine. But waiting to outgrow it is it's gambling a little bit.
Yeah, I can see that point. And I'm sure there are some parents listening thinking, I cannot do another middle of the night wake up call changing sheets. I don't have any sheets left in my house to be changing.
It's a lot of laundry. It's a lot.
It is a lot of laundry on top of laundry we already have. So
Yeah.
I'll be interested in hearing more about that. Are there any tools or items out there on the market? It seems like when you're shopping for, baby, toddler, adolescent tools and tricks, there's so many out there. Are there any you like or any specifically you don't like when it comes to alerting a child about the need to wake up and go to the potty?
So they're all a series of bedwetting alarms, which I think are very reasonable because they're harmless. And what they do is they try to drive that reflex, as we talked about. There's two kind of ways to void. The one sacral reflex, and then the other is the infantile reflex, and then the adult pattern. They try to drive you to the adult pattern, so it recruits the brain. Every time you have to urinate at sleep, it makes sure you're aroused. So it's kind of pushing that signal that way, and it's about the success rates vary so much. You read numbers from 30%, which is placebo, to 60%, but I compared it to like a New Year's resolution that people give up on these things so easily because it's very difficult to wake up with them. But I do think it's much better than just randomly waking up a child, because if you wake them up with even though they've already wet when they set the alarm off, it does build this pattern that could be useful. And there's anecdotal stories of kids being cured with, a one night with the alarm or a month with the alarm. So it definitely can direct children to wake up to avoid, but doesn't allow them typically to sleep through the night. They typically do have to wake up to pee. In terms of bedwetting alarms, there's so many variations. There's some that are clip-on, there are mats. I don't necessarily promote or recommend any brand, but I do think if you have a well-reviewed alarm that's not too expensive, that works well with your family, that I think they are harmless, But like anything else we'll talk about, the more there's a component of constipation or overactive bladder, the less effective it will be, or more difficult it will be to be dry with ancillary measures.
So what I'm hearing you say is it might be worth a try, but it may not get to the root of the problem.
Yeah, and you know what I exactly what I also like it sometimes I use in my clinic as a kind of a poor man's urodynamics. So urodynamics is a test we do in the clinic where we measure bladder function, and you see how much the bladder can hold and how when you void, how much volume you void. So if you use an alarm and you notice that it goes off every 2 hours or early in the night, then you know you're much further from being dry at night than if were to go off at 5 or 6 in the morning. If you follow my logic. So sometimes it does not only can be provide curative effects, but it also can provide kind of diagnostic or data that you can use in care of the child.
That's a great point. Yeah, that's something good to think about as as a parent, you're trying to gather all these reasons why when you
Yeah.
talk to a specialist like this. So these are good things to keep in mind as we're trying, different techniques. So finally, I do want to talk about how constipation, or another way that you put it, might affect potty training in general, but specifically bedwetting.
Yeah. So this is the important thing to keep in mind because I really hear what you're saying because I see it so often where parents are ready to pull their hair out because they did everything. They held the water before dinner, they had them pee before bed, and the child peed like twice in the bed. It's just if you use like pure just what your parent think here, it'll drive you crazy. You have to just remove all emotion and just follow kind of the algorithm. It does help. So think of it this way: if there were not a component of constipation, because a lot of parents say, my child's pooping normally, then there would be no way for the child to pee while asleep, right? They would, if they made too much urine, they would just wake up, And again, the deep sleep thing we can get into more, but when they actually studied it, they found that it wasn't that the children's sleep was disrupted, it was that the bladder spasming. It wasn't the sleep disruption affected the bladder, it was the bladder affected the sleep. So not only if you fix the root cause here, will you improve the bedwetting, but you'll get better sleep. So in short, and anyone that's ever had a child could understand this. Kids put off pooping, right? Every child has a component of that. And it's a very human behavior. Can't think of another animal that does this, volitionally. Um, but we're too smart for our own good. So if we're in the middle of something or we don't like the way it feels, we'll just squeeze our sphincter, put off the pooping, and then the urge to poop goes away, and we reset that to a larger diameter of the rectum. So whatever we thought our body thought was full for the rectum, now we're telling it that's not full. So then it has to get more full to give us that signal. And you
Hmm.
can imagine only a few months of this, and you get your colon pretty much, your pelvis pretty much full of poop. And so what happens is they're not getting the urge to pee until very late, and to poop until very late. And that stretched rectum is stretching the nerves to the bladder, which go to the spinal cord, and that sets off that reflex. So basically, that stretched rectum keeps that infant voiding reflex intact. And
Hmm.
this has been proven. Like the best study was done by Dr. O'Regan in the 80s, where he took bedwetting children, measured their rectal dilations, showed it was dilated, measured their bladder function, and showed it was overactive. He then emptied the rectum with therapies, rechecked the bladder study, and it was normal.
Hmm.
And what throws people off on this is that it's very genetically, there's a large genetic variation in this. In some children, about a third, rectal dilation causes bladder overactivity, which typically presents as bedwetting. In another third, it doesn't affect the bladder at all. So you could have your classmate worse constipation and he's fine. And then in another third, it makes the bladder less overactive or underactive. So that's called lazy bladder syndrome, where these kids, their parents love taking them on a trip because they never had to pee the whole way down. But then maybe they worry about that. But no one comes to very few people come to the urologist saying my child doesn't pee enough. And so we end up seeing these bedwetting kids, and it messes up because parents will say, well, I have 3 other kids. They have a hard time pooping in this one. Why is this one wetting the bed? But when you break it down into the genetics and x-ray them and figure out what's going on, you always find the association of bladder overactivity and rectal dilation.
Hmm. Oh my goodness. I feel like there's so many questions that many of our
Yeah.
listeners can even come through out of that. I'd like to ask a question. How do you even know if your child is constipated? Let's say you have a child that poops once a day, around that, and you say, oh, they've emptied their intestines, they're done. But they're still bedwetting. Do you see that often, or how do you? I guess how do you? What are the signs besides bedwetting that a child might be constipated?
So yeah, the term constipation is pretty loaded because it means so many different things to other people. So I try to focus on the symptoms. So let's take bedwetting alone. If a child is bedwetting and assuming they're otherwise healthy, then they're most likely constipated in terms of our definition, meaning they've delayed emptying of their rectum such that when they do empty now, they don't empty all the way. Um, and that's best diagnosed honestly with X-ray because a lot of parents come in with normal habits. In terms of constipation in general, like what most parents consider constipation, which is not pooping daily or pooping hard rare poops, having a difficult time, then that's kind of obvious. There's a couple of medical kind of questionnaires that can guide you through that. But in terms of like if you have a child that's not wetting the bed and they're pooping enough for you and they're not having any complaints, then that's fine. But belly pain is a common ER visit, and it's almost always constipation, kind of just bloated, passing very large bowel movements. That's always a warning sign. If you look at it and say that's the biggest poop I've ever seen, the reason that's so big is because they've kind of packed it in and they're trying to now pass this huge, abnormally large poop. Chronic diarrhea, any kind of GI complaints. I think it's such a common problem. I think it's the most common medical problem in children that's worth a simple X-ray or an exam to work up. So definitely keep your antenna out for that, and really watch how they do. When they're developing. Kids almost always do really well on breast milk or formula, but the moment you change things up, whether it's rice cereal or cow's milk or table food, antibiotics even, if you change the consistency of the poop, whether it be too loose or too hard, it throws them off and their brain can't handle it and they just start reacting by holding.
Sure. And you mentioned this in your explanation too, that sometimes that holding can start stretching and pushing on different things down there. And if any of our listeners are parents of preschoolers, chances are they butt heads with their child over potty refusal. And you did touch on this. Initially, within my own home, I thought this might be a move to test boundaries and control. But you're thinking it's a sign of a medical issue that might need an X-ray or further examination.
Yeah, so there's different kinds of potty refusal, and the most common is not pooping on the potty. I don't know if that was your experience. And other and pooping is very difficult for kids. It's a mentally taxing activity. You have to, feel it, and then you have to go and kind of let something out that oftentimes isn't comfortable.
Hmm.
And I'm a big proponent of kind of later potty training, which is, some people like it, some people don't. But I'll admit that one of the downsides of late potty training is kids become very comfortable pooping in pull-ups. They just like to
Mhm.
sit in the corner and let it out. I think two things to mention here. One is if the child can't control their bowel bladder at an advanced age, like after 3, coming up on 4, if you try like a diaperless potty training and they're just peeing and they don't even know what's happening, then that's a big warning sign they're constipated because at that age, closer to 4, they should be able to feel the urge to pee and let it out, and they should definitely know they're peeing. Again, when they're peeing and they don't even know they're peeing, and that's that reflex in the sacrum that's not even involving the brain. The other is that kids that are hiding the poop or having to go kind of get their own private time to poop, that to me says they're thinking about it a little bit too much, right? It's an ordeal for them. It's not just a thing like eating or peeing or sleeping. It's a stressful event. They need to kind of
Hmm.
prepare themselves and get in the right environment, and that's a bad sign. There are two specific ways that I've seen that have been published to get children that won't poop on the potty to poop on the potty, and if that would be helpful, I could definitely summarize those.
Absolutely, please.
Yeah, so there's a book called The Ins and Outs of Poop by Duhamel, which is an excellent book. It's very short, easy read, and it's kind of like this slow transition. So you take a kid that's like, we have a lot of them that either won't come out of pull-ups or out of pull-ups completely, but demand a pull-up to poop and won't go in the toilet. And he says, okay, fine, you get them pooping regularly in a pull-up, and typically these children need some laxatives for this. And then you kind of slowly transition them, and you can follow the logic here. Okay, here's your pull-up, you can poop in it. And then, okay, here's your pull-up, you can poop on it in the bathroom. And here's your pull-up, you can poop on it on the toilet, but you have to be wearing it. And then, some kids, they mention you have to literally cut a hole out of the pull-up to make them go because they're so he has a great story in his book where this little girl was pooping in the potty, but she was so dependent on that diaper, and she had never gotten poop on it because it'd been so long because it cut a hole in it, that it was a tattered belt, and they apparently didn't want to buy any more diapers. So she kept on, she'd have to put the belt on. It was like a ritual to get her to poop. So that's this kind of slow and steady approach. And then there's a sink or swim approach, which is developed by Dr. Dom, who tragically passed a couple years ago. But he would use a high dose X-Lax, and he would say, okay, we're gonna overwhelm this urge, because if the urge comes on slowly, as most kids, then they can just squeeze their sphincter and put it off. He said, we're gonna do three things. We're gonna minimize their barriers to pooping, so keep them unclothed, minimize their distance from the toilet, so keep them near the bathroom, and then we give them a large dose of X-Lax. So basically, when the urge hit them, it was coming, ready or not, and so the child almost always made the decision to go in the toilet because there was no other alternatives. And so, and once that happened, even though it sounds a little bit extreme, it would flip a switch in their brain. I've seen it myself several times, and they just, from this holding reflex, they go to a pooping reflex, and that's what you want.
Very interesting. We'll have to check out, all of our listeners will have to check out some of those recommendations and tips and tools. If there's a child in your house that is holding and you're just bashing your head against the wall about why, those are some really actionable steps to take. And once we've moved out of that preschool, pre-K phase, most of us assume that we've moved past all accidents, including bedwetting. But for some of us, that isn't true. And we touched on this at the very beginning. According to the Census Bureau, there are 43 million US kids aged 10 to 19, which translates to over 800,000 bedwetting teens and tweens. Which this statistic in general just breaks my heart, because at least when our child is 2, 3, 4 or so, they might not remember the embarrassment of having an accident at night or the shock or who saw it or whatnot. But teens can. And so, can you fill us in on some of the reasons for bedwetting in older children?
Yeah, and so keep in mind that bedwetting is multifactorial, so that's why you see so many things kind of working in some people. So if you're making a lot of urine, abnormal amounts of urine, then it's going to contribute, right? Your bladder's more likely to squeeze if you're making too much urine. So if you're drinking a lot, but a common cause is sleep apnea, which can make you have a diuresis. And so some kids go to get their tonsils out and they'll see some maybe temporary improvement. It's not a 100% cure, but sleep apnea is something to consider. And then there's genetic variations in terms of how much rectal dilation from this delayed pooping will affect your bladder. Some kids need just a tiniest amount of rectal dilation, sets their bladder off. Others need significant amounts of rectal dilation. And as you develop more mature pooping patterns, you're letting out poop on time, hopefully, then you may have these resolution at different ages, and some people may never develop normal pooping patterns, so we have to help them a lot. And so I think that the thing that tricks families, they see different kids. Well, my kid did an alarm, my neighbor's kid did an alarm and they were better, and so my kid just, when they went through puberty, they got better. You have to focus on the facts that something is setting off this void that never gets to the brain. And so, okay, we can make it better with some meds, maybe we can make it better by limiting fluids, but to really get that reflex turned off, we have to address the rectal dilation, and getting an X-ray will diagnose that. And and I say that like it's a simple thing. You actually have to get the X-ray and then have someone look at it that knows what they're looking at, because unfortunately, most radiologists, although well trained, don't consider poop abnormal. So you have to have someone that's used to looking at these X-rays, which would be like somebody like me, or a urologist, to give you the right read. And I've heard so many family stories of being kind of brushed aside by physicians, and so it does get a little upsetting and tragic. So I encourage families to kind of work through this and get the answers they deserve, because bedwetting is not normal and you can cure it at any age. Dr. O'Regan, who was the father of kind of all my research, he started all this field of research, cured his own son at 4. And so it's never really too young, other than, a baby in a crib, where you can address this topic and get them dry and build their confidence.
Sure. And we talked in the beginning, about trying to remove, maybe the parental emotion away from the situation and try to look at those facts. But the fact of the matter is that it is an emotional thing, no matter what age your child is. We talked about sleep deprivation, which of course can be very emotional, but also just that you care about your kid and you don't want them to be going through their whole life like this. And of course, so much of our kids' reaction is what we react to the situation.
Yeah.
We never want kids to feel shamed or like there's
Hmm.
something wrong with them, especially when it is a reflex or can be a reflex situation, like we've been talking about. So, how should we be talking about accidents and bedwetting at home? I'd love for you to give us maybe some kind of tips or scripts, examples for a younger child and an older child.
Yeah, I think my script is pretty consistent for all ages. I adapted obviously for my audience and what they can understand, but I like to focus on two things: what they can control and what they can't control. And so, starting with what they can control, is I tell them when they're leaving the clinic, this is your one job. This is all you got to do. If you feel like you have to poop, you have to go right away. Okay, so because that's kind of the opposite of what started the problem, which is delayed pooping. So that I give them that order, and they're usually pretty good on that. And sometimes I'll use the anecdote that the average, if they know what a mammal is, the average mammal poops in 12 seconds, right? Most kids are pooping in 12 hours, it seems like. So I get them to focus on going when they feel it, and it should go quick and easy, and that's something actionable for them. And then what they shouldn't worry about, what they can't control, I really focus on the fact that this is kind of part of their makeup. I compare my office because I'm a urologist with stones a lot of times. Kids come to my office, they have kidney stones, and it's a genetic problem. And you'd be surprised how many kids have stones, and they probably drink as much as their classmates, right? They're not doing anything wrong. They had a normal diet, they have a normal intake, and they just form kidney stones. So it's kind of not fair. They have to drink way more than
Mm,
your average kid to prevent these stones, and they have to really limit their diet to not get these stones. And so it's not right or wrong. It's just kind of everyone's got a cross to bear. And unfortunately, for some kids, there's something difficult like this, which can be hard even for adults, to limit their diet in certain ways. So I try to focus on those components, and hopefully that makes them feel better about it, and that really push the it's not their fault component, because I see parents getting frustrated. I mean, I've been there, and so really try to remind them that um, they're doing the best they can. Their body is doing it without their knowledge when they went to bed.
sure. Those are good things for us to keep in mind and good things for us to kind of regurgitate to our kids when they're going through these hard situations, because obviously they don't want to be woken up in the middle of the night in an unpleasant situation either.
Yeah.
So thank you so much for that. This was so informative. I feel like I could talk to you for another hour, but we do need to wrap up. I'd love to know if you have some kind of top tip or best parent advice for kids who have nighttime accidents in conclusion.
Yeah, I give everyone a three-step program that it works for everyone. You know, at some point, it says I'm not make it sound easy. You have to work through it. And keep in mind that throughout the three-step program, you can always be doing the bedwetting alarm in the background, because the alarm's kind of ancillary. And the first step is addressing the bowel issue. I promise you, if your child is otherwise healthy and wetting the bed, they have a component of rectal dilation, or you can call it constipation. You can get an X-ray and get that diagnosed, and then you can treat that. It's frustrating, I realize, because parents may buy into it and say, okay, my kid is constipated, then give their child laxatives for a month and say he's been pooping great, he's still wetting the bed. Then that's when you go back to the X-ray and say, look, we haven't made a dent in the X-ray. It's tough. So just because constipation is number one cause of bedwetting doesn't mean it's easy to fix. It can be onerous, and we have a whole variety of programs we've used to get kids empty. As long as you focus on the prize, which is getting them dry, or if they're not dry, check the X-ray and then modify your program, you will get there. Some people can't do that, or they need extra help, or they want to get dry a little faster. So you can add medications. That's the second step. These medicines will either make the urine output less at night, or make the bladder hold more urine at night, so they can be drier sooner. It does cover up the problem. So if you were to stop these medicines, they would wet the bed again. But to a child that's dry, they don't care as long as they're dry. Build self-esteem. So I do offer meds to patients if they want them, keeping in mind that it's not really a long-term cure. The bowel program is a cure. And then if I have an older child that's like about to go to college and they're still wetting the bed and they don't have time to go through all this or they tried it, I do have some success with Botox. It sounds crazy, but basically the medicines that allow the urine to bladder hold urine that are given orally are pretty effective, but Botox is much more effective. So if you have a child that's got a time constraint in terms of getting dry, it's an expensive and temporary but effective option for bedwetting.
Wow, my mind is
Yeah,
blown.
yeah, there you go.
But those are great. I mean, like you said, there are three options for solutions, and
Hmm.
I feel like at least one of those three resonates with everybody listening. So we really appreciate that, knowing there's hope and there's solutions on the horizon. We really appreciate that. And thank you so much for joining us today, Dr. Hodges.
Thanks so much for having me. I hope it helps some kids.
Absolutely. For our listeners, thank you so much for joining us today. And please find more presentations by nationally renowned experts like Dr. Hodges through membership in the Modern Art of Parenting website. Visit modernartofparenting.com to learn more about memberships, which are just $19 a month or $199 for the year with a 30-day money-back guarantee. Thank you, everyone, for listening, and join us next time on Raising OKC Kids.